This is Raby. These slides are a summary of the current American College of Cardiology American Heart Association guidelines for how to approach preoperative risk assessment for patients undergoing non-cardiac surgery. First, valvular heart disease. When to do an echocardiography and a consult. In aortic and mitral stenosis or insufficiency, when there is no dyspnea, chest pain, or syncope at relatively modest exertion, that is New York Heart Association Class 3, or where there is no history of any left ventricular dysfunction, there is no need for a pre-op echocardiogram as long as it's been done at some point within the last year. If you have symptoms of dyspnea, chest pain, or syncope at relatively modest workload, that is New York Heart Association Class 3, get a pre-op echo and refer those patients to cardiology because they have significant symptoms possibly related to their valvular disease, and that needs to be taken care of before they get anesthesia. Okay, specifically for aortic stenosis, if you have New York Heart Association Class 3, dyspnea, chest pain, or syncope, that is, you get these symptoms with routine activities, or you have LV dysfunction, you're at high risk for morbidity and mortality if you have non-cardiac surgery. And you probably ought to have the valve fixed anyways. That is true except if you're having minor surgeries such as cataracts or a finger procedure or something like that. Similarly for mitral stenosis, if you have class 3 symptoms, dyspnea, chest pain, or syncope, or a history in this case of severe pulmonary hypertension, then you are at high risk for mortality and morbidity in non-cardiac surgery. And again, you have symptoms that warrant correcting the valve anyways, except if you have minor surgery. In patients with aortic or mitral insufficiency, those lesions are a little more forgiving. First, once again, if you have significant symptoms with routine activities, New York Heart Association Class 3, dyspnea, LV dysfunction, or severe pulmonary hypertension, you warrant valvular surgery anyways. It may as well be done prior to elective non-cardiac surgery. Insufficiency is not as risky, though, if left alone, even in highly symptomatic patients. So if for any reason valvular surgery is contraindicated, those patients can proceed with really needed non-cardiac surgery, provided they go to an ICU in the post-op setting for monitoring. Okay, so we move on now to coronary artery disease, which is by far the more common issue. Okay, so the first approach is if a patient gives you a history that's consistent with unstable angina or unstable heart failure, with minimal activities at rest, postpone all but the most emergent surgeries and refer them to cardiology. They are at very high risk. Next, if they don't have unstable symptoms, ask yourself what the surgery type is. If it's minor, such as cataract, ophthalmology, dermatology, minor orthopedic, they really don't need testing unless they are supremely unstable. They should just go ahead and have those surgeries. But if they have more moderate or major surgeries, such as major orthopedic, gastrointestinal, pulmonary, or vascular surgeries, the next thing you should do is assess their functional capacity. What does that mean? Ask them what their activity level is. And I reference here the Duke's Activity Status Index, which is used very commonly. Are you able to walk up 2 flights of stairs? Do routine housework without angina or heart failure? If you do, you can proceed without referral to cardiology or testing. If, on the other hand, you are unable to walk up 2 flights or do routine activities, it's not clear that you don't get angina or heart failure at minimal activity. So here you ask yourself, what are the patient's risk factors? Do they have prior myocardial infarct, prior coronary interventions such as coronary artery bypass surgery or percutaneous coronary intervention? Are they hypertensive? Are they diabetic? Do they have hyperlipidemia? Or are they smokers? If they have any of these risk factors, then you should consider preoperative testing for moderate-sized surgeries. Typically, these patients are unable to walk very far, so you should consider a chemical stress test. If they don't have any of these risk factors, they're still at very low risk for cardiac events because they likely don't have coronary artery disease. But they do have limitations in functional capacity, and maybe you should investigate non-cardiac causes of functional incapacity, such as COPD or significant renal failure or significant anemia. Okay, a few bullet points about preoperative cardiac testing. Everybody should have an ECG unless you're very young. In the case of women under the age of 45, in the case of men under the age of 40, and you're undergoing minor surgery. People should have echocardiography only if they have suspicious symptoms. That is dyspnea, valvular heart disease from prior history, prior known LV dysfunction, and if it has not been assessed in over a year. Coronary angiography should only be done in people who have clear-cut symptoms of unstable angina or are at very high risk with respect to a positive stress test that's very high risk. Not all positive stress tests should go to coronary angiography prior to non-cardiac surgery. Okay, other issues. If antiplatelets have to be stopped, that is aspirin, or in the case of people who've had coronary stents in the past, Plavix or a similar medication. First of all, elective non-cardiac surgery should be delayed if you're on dual antiplatelet therapies, if you've had an angioplasty in the last 14 days, if you've had a bare metal coronary stent in the last 3 days, and per current guidelines, if you've had a drug-eluting stent in the last year. If you've had a drug-eluting stent and the surgery is elective, you have to wait a year before you can stop Plavix for those patients. That may be changing very soon because modern-day stents are proving safer, and in cases where the surgery really cannot be delayed, drug-eluting stent-receiving patients can conceivably have their Plavix or equivalent stopped at 90 days, and certainly at 180 days if necessary. Current guidelines are still 365, but that may be changing. If you've had coronary bypass surgery, you probably ought to wait about 6 weeks before stopping any antiplatelets. Ideally, aspirin should never be stopped once you've had a coronary stent or coronary bypass surgery. The risk of an abrupt stent thrombosis or abrupt graft thrombosis is real, albeit very small and less than 1%. Most surgeries, including GI, orthopedic, and most neurosurgeries, can be done on a baby aspirin alone. Most surgeons believe that. Certainly vascular surgeons insist on baby aspirin remaining. But dual antiplatelets, those can be stopped according to the guidelines we've already talked about. Urgent surgery within the above time window can be done. A cardiologist should be consulted, and typically those patients have to have bridge therapy with intravenous antiplatelet drugs until only a few hours before surgery, with those antiplatelet drugs restarted right after surgery. Okay, other drugs. Beta blockers remain somewhat controversial, but the current guidelines are the following. If you're already on a beta blocker, continue the beta blocker perioperatively. You should be on a beta blocker if you have active myocardial ischemia. What does that mean? You have class 2 angina or greater, or have a positive stress test. Start beta blockers for 3 or more of the following. If you're diabetic, if you've had a prior MI or coronary intervention, if you have stable CHF, if you have some renal insufficiency, that is chronic kidney disease stage 3 or greater, if you've had a stroke or peripheral vascular disease. Why? Because you're very likely to have coronary artery disease under those circumstances. Beta blockers in those circumstances should be started at low doses. Example, metoprolol XL 25 milligrams, tenolol 25 milligrams, something along those lines, and at least 24 hours pre-op so as not to incur hypotension during the operative day. Other agents, continue ACE inhibitors and ARBs if you're already on them. Continue statins perioperatively if you're already on them. And certainly start statins in someone who is not on a statin who happens to be diabetic, have known coronary disease, or is having vascular surgery. Avoid alpha-2 blockers. These are the prostate drugs, tirazosin, doxazosin, etc., for cardiac risk prevention. They are okay to continue if they're being used for urology. Prophylactic and intraoperative nitrates have not been shown to be effective in reducing cardiac events at all. Postoperative neuroaxial and epidural anesthesia have been shown to reduce perioperative cardiac events, and those are typically decisions made by the anesthesiologist, and they're more frequently used among patients with coronary artery disease. Few final things. If you have an implantable defibrillator and you're going to have non-cardiac surgery, the recommendations are first to inactivate the tachytherapy, that is, put a magnet on the defibrillator so it doesn't shock, especially if a cautery device is being used, because the defibrillator will interpret cautery as ventricular fibrillation and shock the patient. Of course, once the magnet is on the defibrillator, there has to be continuous perioperative EKG monitoring so as not to miss ventricular tachycardia if, God forbid, it occurs. And then the device has to be reprogrammed. Typically, we contact the company rep who comes in postoperatively and make sure that the device is back to its original programming. And that is it. Thank you very much.